Okay, so guys, welcome to the part 3 of the chapter 241 of your Harrison's textbook of internal medicine, which is about non-invasive techniques. And now we'll discuss the application of these non-invasive techniques for the diagnosis of valvular heart disease. Now, abnormalities of any of the four cardiac valves, aortic, mitral, tricuspid, or pulmonary, can result in significant cardiac dysfunction, obviously. These abnormalities may progress to heart failure and, if untreated or severe, can ultimately lead to the death of a person. So, क्या क्या हो सकता है? Several imaging modalities are available for evaluation of valvular heart disease. इलेक्ट्रोकार्डियोग्राफी कर सकते हैं, कार्डियक मैग्नेटिक रेजोनेंस कर सकते हैं एंड कार्डियक कंप्यूटेड टोमोग्राफी सीटी भी कर सकते हैं. Okay, among these, echocardiography is generally considered the first line and primary imaging test for assessment of valvular heart disease. This is because echocardiography is widely available, non-invasive, portable, able to provide real-time assessment of valve structure and hemodynamics. Plus, echocardiography is the most cost-effective screening method for detecting valvular heart disease. लेकिन कभी कभी we also need CMR. CMR can complement echocardiography, particularly when the echocardiographic acoustic window is inadequate, when more precise quantification of blood flow area is required, and when additional assessment of adjacent vascular structures relevant to the valvular condition is necessary. So, अब echo की महिमा. Echocardiography can be used to assess both regurgitant and stenotic lesions involving any of the four cardiac valves. Typical indications of echocardiography in valvular heart disease are common clinical indications क्या क्या हैं? Cardiac murmurs अगर आ रही हैं, if they are identified during physical examination. Symptoms of breathlessness which may be secondary to valvular dysfunction. Syncope or pre-syncope which may reflect as severe valvular obstruction. And preoperative evaluation of patients undergoing coronary artery bypass surgery. इन सभी के अंदर हमें इलेक्ट्रोकार्डियोग्राफी करनी होगी. So a standard electrocardiographic examination should include both qualitative and quantitative assessment of all the cardiac valves. It should be performed regardless of the primary indication and should serve as an adequate screening test for identifying significant valvular disease. So that's what a standard echocardiographic examination should look like. अब चार valves हैं तो चारों valves की बात होगी. सबसे पहले aortic valve, तो assessment of aortic stenosis. Aortic stenosis is one of the most common forms of valvular heart disease. It most often occurs due to gradual progression of valvular calcification, which may affect previously normal valves and congenitally abnormal valves. So दोनों aortic valves इससे affect हो सकते हैं. तो अब हम क्या क्या investigations कर सकते हैं? We can do echocardiography is the most commonly used modality for assessing aortic stenosis. Cardiac magnetic resonance techniques for quantitative assessment of aortic stenosis have been developed and are increasingly being used, particularly over the past decade. अब आगे आइए echocardiographic assessment पे. Echocardiographic assessment is the initial visual inspection. It begins with the visual inspection of the valve, which allows the assessment of valvular morphology, whether the valve is tricuspid or bicuspid, or a variant morphology, and the degree of leaflet calcification and leaflet exclusion during systole can also be identified. So normal and abnormal aortic valve anatomy है कि normal aortic valve consists of three cusps. Okay, so there is a right coronary cusp, left coronary cusp, and non-coronary cusp. Abnormalities in cusp development represent some of the most common congenital heart anomalies, and the most common congenital abnormality is the aortic valve is the bicuspid aortic valve, in which there are two opening leaflets instead of three. So aortic valve should have been tricuspid, लेकिन अगर दो ही cusp हैं, so we will do an echo, and on echo the aortic valve can usually be visualized. However, it is sometimes difficult to distinguish a true bicuspid valve from variants such as the presence of a vestigial commissure or raphe. Now, the bicuspid aortic valve is one of the most common congenital anomalies, and this predisposes to both aortic stenosis and aortic insufficiency. So, ये तो आपने basically एक echo कर लिया. Now, quantitative assessment कैसे होगा? Quantitative assessment of aortic stenosis severity is done by estimating the pressure gradient across the valve and the valve area. Okay, so the velocity and gradient criteria क्या है? In patients with moderate aortic stenosis or worse, generally demonstrate peak instantaneous velocities more than equal to 3 meter per second. And if velocities are more than equal to 4 meter per second, then it is more common in more severe diseases. These velocities correspond to pressure gradients of 3 meter per second वाली अगर velocity चल रही है, so हमने बोला था ना delta b is equal to 4v square, so pressure gradient approximately 36 mmHg होगा. Okay, 3 का square 9, 9 4 36, और अगर 4 मीटर पर सेकेंड चल रही है तो 4 का स्क्वायर 16, 16 4 जा 64, तो 64 मिलीमीटर्स ऑफ मर्करी यहाँ पर प्रेशर का ग्रेडियंट होगा. Next up is the valve area estimation. In patients with severe left ventricular dysfunction, pressure gradient across the aortic valve may be underestimated. In such cases, estimation of valve area using continuity principle is considered the most accurate technique for assessing the severity. So types हो सकते हैं aortic stenosis के. One is low flow, low gradient aortic stenosis. Evaluation of patient for this can be particularly challenging. In these patients, provocative testing such as dobutamine stress echocardiography may be required. The key clinical distinction to determine whether the valve is capable of opening further with the increased flow or the valve is truly stenotic but appears less severe due to transvalvular pressure gradient. So हमें इसमें determination लेनी है कि valve या तो खुल सकता है या फिर completely stenosed है, लेकिन severe इतना लग नहीं रहा क्योंकि transvalvular pressure gradient इतना ज़्यादा नहीं है. So what are the severity cutoffs? Aortic valve area less than 1 centimeter square determines severe aortic stenosis, and aortic valve area less than 0.6 centimeter square corresponds to critical aortic stenosis. However, in patients with preserved left ventricular function may tolerate severe aortic stenosis for long periods. Therefore, valve area or gradient alone should not be used to decide on surgery. The decision for aortic valve surgery remains a clinical decision. So this was it. अब आता है subvalvular and supravalvular obstruction in aortic stenosis. So in addition to obstruction at the level of aortic valve leaflets, the left ventricular outflow obstruction can also occur. So below the valve है तो subvalvular, above the valve है तो supravalvular. These forms of obstruction may mimic valvular aortic stenosis clinically also and hemodynamically also, but the etiology, anatomy and management differ. So सबसे पहले हम बात करते हैं subvalvular aortic stenosis की. Subvalvular obstruction is most commonly by a discrete fibrous membrane or ridge located in the left ventricular outflow tract LVOT just below the aortic valve. So in this condition is often congenital and may progress over time due to increasing fibrosis. So echocardiography allows here the visualization of subvalvular membrane, the assessment of the level of obstruction and differentiation from valvular aortic stenosis based on the location of the highest velocity jet. So at the level of valve या फिर after the level of valve है ये पता लगाने के लिए we will do this. Next up is the supravalvular aortic stenosis. Supravalvular obstruction occurs above the aortic valve, typically involving the ascending aorta. Okay, this form of obstruction is often again congenital, may be associated with systemic syndromes. So echocardiography can identify narrowing of the ascending aorta, and this is demonstrated at elevated velocities distal to the valve. However, due to limited acoustic windows, CMR or CT may be required to better define the extent, severity and the anatomic characteristic of the supravalvular narrowing. So what is the role of multimodality imaging in aortic stenosis? Concluding this, although echocardiography remains the cornerstone of aortic stenosis evaluation, additional imaging modalities play important complementary roles. क्या क्या हम कर सकते हैं? CMR कर सकते हैं, cardiac magnetic resonance. This can provide accurate assessment of the left ventricular volumes and mass, precise quantification of blood flow, and assessment of myocardial fibrosis. And CMR is particularly useful when echocardiographic images are technically limited and is more accurate volumetric or flow quantification is required. Now coming on to CT, cardiac computed tomography has become increasingly important in quantifying the aortic valve calcification and assessing annular size and anatomy. CT based calcium scoring of aortic valve भी हम इससे कर सकते हैं. This provides a quantitative information about the valve calcification and is particularly helpful in patients with discordant echocardiographic findings, जहाँ पर echocardiography से हम बहुत ज़्यादा clear determination of result नहीं कर पा रहे हैं, and patients with low gradient severe aortic stenosis. Okay, now there is transcatheter aortic valve replacement technology, TVAR. Imaging considerations क्या क्या होने चाहिए यहाँ पे. The development of transcatheter aortic valve replacement has expanded the importance of multimodality imaging. So there is a pre-procedural imaging. Before TVAR, imaging is required to assess aortic angular dimensions, evaluate valve morphology, and define the extent and distribution of calcification. Also to assess vascular access routes कि हम लोग जाएंगे किस route से. Cardiac CT is the preferred modality for the assessment of this because it has a high spatial resolution and the ability to provide precise annular measurements and a capability to assess iliofemoral vessels. So procedural and post-procedural imaging क्या होंगी यहाँ पे. During and after TVAR, echocardiography चाहिए हमें to confirm prosthetic valve की position, assess for paravalvular regurgitation and evaluate prosthetic valve का function. So this was all about aortic stenosis. Now coming on to aortic regurgitation. So assessment of aortic regurgitation, this results from an inadequate coaptation of the aortic valve leaflets, बंद नहीं हुआ गेट ढंग से. So leading to retrograde blood flow from the aorta to the left ventricle during the diastole period. So the severity of aortic regurgitation depends on the size of regurgitant orifice, the diastole pressure gradient between the aorta and left ventricle, and the duration of diastole. So हम क्या कर सकते हैं. Echo करा सकते हैं. Echocardiographic evaluation is the primary imaging modality for evaluating aortic regurgitation. It provides the assessment of valve morphology, mechanism of regurgitation, severity of regurgitant flow, and effect on left ventricular size and function. So what will be the mechanisms of aortic regurgitation? This may result from primary valve leaflet disease such as congenital abnormalities or degenerative changes. Aortic root dilatation can also lead to this, which will lead to inadequate leaflet coaptation despite structurally normal leaflets. Aorta ही dilate कर गई है. So जो valves हैं that they won't be able to oppose. So echocardiography allows differentiation between primary valvular causes and secondary causes related to aortic root pathology. Now coming on to the quantitative and semi-quantitative assessment for the same. Severity of aortic regurgitation is assessed using color Doppler imaging, continuous wave Doppler, and assessment of left ventricular size and function. Now chronic severe regurgitation will lead to progressive left ventricular dilatation, compensatory increase in stroke volume, and eventual left ventricular systolic dysfunction if it is left untreated. Okay, so this was about the aortic valves. Now coming on to mitral valves. The assessment of mitral stenosis. Mitral stenosis is characterized by obstruction to blood flow from the left atrium to the left ventricle during diastole. The most common cause of mitral stenosis worldwide remains rheumatic heart disease, although other etiologies may also contribute in selected patient populations. Now, imaging plays a central role in confirming the diagnosis, determining the severity, assessing the hemodynamic consequences, and guiding timing and type of intervention. So, role of echocardiography क्या है in mitral stenosis? Echocardiography is the primary imaging modality for evaluating mitral stenosis. It allows a direct visualization of mitral valve morphology and a measurement of mitral valve area. This allows estimation of transmitral pressure gradients also. Okay, now it also allows the assessment of left atria की size and evaluation of pulmonary artery pressures. It allows identification of associated valvular lesions. Now, what are the morphologic features which we see for mitral stenosis in echocardiography? Typical echocardiographic features include thickening of mitral valve leaflets, restricted leaflet motion, fusion of commissures, subvalvular apparatus involvement including the caudal thickening, caudal shortening, and the classic hockey stick appearance of the anterior mitral leaflet during diastole reflects restricted posterior leaflet motion and commissural fusion. So hockey stick appearance is important here. Up severity. So the assessment of severity is primarily by mitral valve area and again the mean transmitral pressure gradient. Likewise we were doing for the other valves. So in mitral valve area can be estimated by planimetry on 2D echocardiography and pressure half time method using Doppler imaging. A mitral valve area less than 1.5 cm square generally indicates severe mitral stenosis with smaller areas associated with more advanced disease. Okay. Now coming on to the transmitral pressure gradient. So the transmitral pressure gradient will reflect the hemodynamic burden of obstruction. This is influenced by heart rate, cardiac output and rhythm. For example, the rhythm will increase in atrial fibrillation. Therefore, gradients must be interpreted in conjunction with valve area and clinical context. So role of stress testing क्या है यहाँ पर? In selected patients with symptoms disproportionate to resting echocardiographic findings हम लोग stress testing करा सकते हैं. Exercise or pharmacologic stress echocardiography may be used to assess the changes in transmittal gradient and evaluate exercise-induced pulmonary hypertension. So this was about mitral stenosis. Now coming on to the assessment of mitral regurgitation. Mitral regurgitation results from incompetent closure of mitral valve leading to retrograde flow from the left ventricle to the left atrium during the systole. Mitral regurgitation may be primary or organic due to intrinsic valve disease and secondary or functional due to left ventricular remodeling. So role of echocardiography in mitral regurgitation क्या है? Echocardiography is essential for identifying the mechanism of regurgitation, quantifying the severity, assessing left ventricular and left atrial remodeling, and determining the timing of surgical intervention. तो mechanism क्या है? Primary mitral regurgitation हो सकता है caused by abnormalities of valve leaflets, chordae tendineae और papillary muscles. Common mechanism include degenerative disease and rheumatic involvement or endocarditis can be there. In case of secondary or functional mitral regurgitation, this occurs due to left ventricular dilatation. So there will be papillary muscle ka displacement and annular dilatation. In these cases, valve leaflets are structurally normal, but क्योंकि geometry बिगड़ चुकी है, regurgitation results from altered ventricular geometry. So अब severity कैसे quantify होगी? Severity is assessed using integrated approach including color Doppler jet characteristics, continuous wave Doppler signal density, pulmonary vein flow patterns, left atrial and left ventricular size. Now this chronic severe mitral regurgitation will result in progressive left atrial enlargement, obviously, left ventricular volume overload and eventual left ventricular systolic dysfunction. Mitral regurgitation हो रहा है बार बार तो वॉल्यूम ओवरलोड होगा एंड दिस विल रिजल्ट इन लेफ्ट वेंट्रिकुलर सिस्टोलिक डिसफंक्शन. सो अदर देन इको हम क्या कर सकते हैं? CMR करा सकते हैं. CMR कैन बी यूजफुल व्हेन इकोकार्डियोग्राफिक फाइंडिंग्स आर इनकंक्लूसिव एंड प्रिसाइज क्वांटिफिकेशन ऑफ regurgitant volume and fraction is required. So this CMR will provide highly accurate measurements of ventricular volumes and flow quantification without geometric assumptions. Okay, so we have completed the aortic stenosis and regurgitation and mitral stenosis and regurgitation. Now, some short discussion about the tricuspid and pulmonary valve disease. Tricuspid and pulmonary valve disease are less common than left-sided valvular disease, but may significantly impact some clinical outcomes. So, tricuspid valve disease is most commonly secondary due to right ventricular dilatation or pulmonary hypertension. So echocardiography will allow the assessment of tricuspid valve morphology, estimation of right ventricular systolic pressure, and evaluation of right ventricular size and function. About the pulmonary valve disease, it's uncommon in adults and usually is congenital or related to prior surgical interventions. Echocardiography remains the primary imaging modality in this also, although CMR may be used for detailed assessment of right ventricular volumes and flow. So now this completes our discussion about the valvular diseases. Okay. Now a general discussion about role of imaging in follow-up and timing of surgery. So imaging is obviously critical in monitoring the progression of disease identifying the subclinical ventricular dysfunction, and determining optimal timing for surgical or transcatheter intervention. Decisions regarding intervention are based on the symptom status and the severity of valvular lesion and impact on ventricular size and function. So, the imaging findings must always be interpreted in conjunction with clinical assessment and used to guide individualized patient management. Okay, so this completes our chapter on non-invasive techniques for evaluation. Next up, we'll be doing the angiography and that part, okay, in the chapter 242. Before that, we'll be covering the images and tables from the book, and then we'll progress to the next chapter, okay. So like to subscribe. Thanks for watching. Keep studying.